Wonderful.
Thank you. Good afternoon, everyone. We're back with the House Healthcare Committee. It is still Friday, January 13th. And we are excited to have the Green Mountain Care Board with us today. So we will do introductions since it's your first time here and many of us are new. And I also want to say we have adapted an informal process here where we are using first names. Hopefully you're both comfortable with that. So if not, feel free to use last names if you'd like. So we're going to start with introductions with Art this time. I go back and forth. Surprise everyone.
Representative Art Peterson from Clarendon, Rutland District 2, Clarendon, Wallingford, West Rutland, and Rutland Town.
And Leslie Goldman from Wyndham 3, Rockingham, Westminster, Brookline. That's the Bellas Falls area.
I'm a little easier than that, I think. Just Winooski, and I'm Daisy Berbecco.
Mari Cordes, the nurse from Lincoln.
And Topper McFawn is not here. He will actually be coming back, but then leaving again, but he is our vice chair. Lori Houghton, and he's from Barry. Lori Houghton, City of Essex Junction.
Alyssa Black, Northern Essex.
Alan DeMar, representing Montgomery and Enosburg Falls.
My name is Joe Andriano. I'm from Orwell. I also represent Shoreham, Whiting, Sudbury, and Hubbardton.
And I'm Bobby Farley-Trujillo from Barnet, also represent Reigate and Waterford.
Great. If you both want to introduce yourselves.
Sure. I'm Owen Foster. I'm the new chair of the Care Board. I started in October of 2022, so about 3 months. Some of this is new to me, as it is to some new members here.
Robin Lunge, I've been on the board for a little over 6 years now. Prior to that, I worked for the former Governor Shumlin on healthcare reform. And prior to that, I spent about little less than a decade as legislative counsel.
Great.
Which is how I know Topper from when I was working here, and he was in human services.
All right.
Yeah, Topper and I go way back.
Do you want to do a quick introduction?
Topper McFawn. I represent Barrytown and part of Williamstown, and I live in the great town of Barry.
And he may be stepping out, but.
Yeah, I will.
Great. So we're going to let you kick it off. Do you want questions during the presentation, or would you like us to hold them?
Whatever you prefer. If there's questions that come up, this can be interactive if you'd like.
Okay.
Want to hold whatever you guys prefer.
Okay. We'll be interactive, but I will watch the time and make sure that we get, well, I'm not going to make sure we get through the presentation because with Green Mountain Care Board, we tend to not make it all the way through the presentation, but we'll try. And we have all afternoon, but we want to be cognizant of your time and the weather. So maybe we'll check in around 2 and see where we are. Great. Okay, perfect.
Are our slides working? Oh, great.
Yeah.
Good. All right. Well, first, as I said, I'm Owen Foster, and I want to thank you all for having us and giving us a chance to come in and tell you about who we are and what we do. And I want to thank you all for your service. Putting yourself out there and campaigning is hard work, and legislating is hard work. And we really appreciate it. And you must have a kinship with representing Vermonters because it's not easy, and you have a lot of disparate topics to address and understand, and they come at you fast and furious. And as a new Care Board member, I'm going through that as well. But I can tell you the Care Board staff is extremely helpful and a great resource, and they do it with me, and they'll be happy to do it with any other new members on this committee. So I'll tell you a little bit about myself, just so you kind of know who I am. I live in Jericho, Vermont, Essex, Vermont, and we have 2 young daughters. And before this job, I was at the United States Attorney's Office as an assistant United States attorney. I worked on healthcare fraud cases, a lot of cases involving electronic medical record companies for fraud and kickbacks. I also did some pharmaceutical prosecution. The one most people would be familiar with is Purdue Pharma, which had some issues with some kickbacks in connection with their opioid sales. And I know that's a topic here in the building as you deal with some of the money that has been allocated to the state based on the settlements. So we did the federal side of that and the criminal side of that case that is now went through bankruptcy and it's being appealed. But in any event, so I was part of that money process. Before that, I also did some medical malpractice defense of some FQHC doctors. I represented one in Stowe, Vermont, who had a patient pass away when they didn't get an MRI. I don't think it was the doctor's responsibility. I don't think it's her issue. So I experienced that kind of work. I also represented a doctor at the Burlington FQHC, the Federally Qualified Healthcare Center. There's a woman named Byers. She had a CT scan done up at UVM in the emergency room. The scan was never read, and she passed away from stage 4 rectal cancer that was never found, leaving 2 young children. She was from Essex. So I've seen and worked with physicians in my past role. I prosecuted folks involved in the drug trade here in Vermont, opioids, meth, amphetamines. I did some prosecution of folks involved with firearms in the drug trade here in Vermont. So I have some worldview in that connection. Also random things like representing the post office in like slander cases or like FOIA requests or any other random things that came in, which there are a lot. Before that, I was at a large law firm in Boston doing securities litigation and cybersecurity work, representing mutual funds and some stuff with like Bernie Madoff's fraud, a series of cases on that kind of work. Before that, I was in law school, college up the road in Burlington, and before that, I grew up in Middlebury, Vermont, on a family farm. Have family in Orwell, Shoreham, grandmother's from Orwell.
Wow.
So our farm is between A&W Root Beer on Route 7 and Foster Road on Route 7.
Yep.
Yeah.
We're right across the motors.
Yeah, right. That's my cousins. So if you go between those two data So if you go between those 2 data points, that's where I grew up, back there on a farm. My brothers are still living there and my parents are still in the area. A lot of cousins.
So I'm going to say, we could spend days talking to Owen about his experience and the stories he could tell. We have one question I'm allowing on this topic, and that's Tamari, and then we're going to move on, because
She was laughing at me because I think she knows what I'm going to ask. How familiar are you with PBMs in vertically integrated?
And we can also take that
offline. We should take that offline, but
Okay.
I'm familiar with PBMs, yes.
Oh, boy.
So in any event, that's a little bit
Good.
about who I am, and I'll let Robin explain some of her background a little bit. Committee.
Sure. I gave you the short version, but I grew up in Brattleboro and went to school in California because I wanted to try something completely different. Came back quickly. After college, went to law school at Cornell. Then I worked for the Vermont courts, Vermont Legal Aid, and then I came to the legislature. And pretty much have been in healthcare ever since then, which was 2003. So a long history, and pretty much until very recently, pretty much anything in Title 18 or Title 8 of the Green Books has my fingerprints on it somewhere from when I was here.
Great. And you've been a huge asset to our committee over the years, so. Great.
And a wonderful asset to the board as well, with that history and knowledge. So if we can go to the next slide, this is who we are. The Care Board was established in 2011 through Act 48. We have 5 board members. There's 3 in addition to Robin and I. And I'll give you a little bit of who they are. Jessica Holmes, she's a PhD in economics and a professor at Middlebury. And Dr. David Merman is the other new member. He started the same day I did, October 1st, 2022. He's a practicing physician in the emergency department at CVMC. So he brings a really clinical voice and viewpoint to all of the work we're doing. And then Tom Walsh has been on the board for about a year, I believe. And he's a physical therapist, and he has a PhD in health policy and clinical practice. He also teaches at Dartmouth, I think Boise State, and a couple other places. We're appointed to 6-year staggered terms. And for those who haven't dug into the process, there's a nominating process that's codified in the statute, Title 18, and it allows that the nominating committee is comprised of representatives and senators and community members. And it's bipartisan, and a board member has to submit an application to them. And then if you go through the interview process and your name is passed along through the nominating committee, your name can go to the governor and they can interview you or select you if they choose. So that's an important thing because it makes it somewhat non-political in that you have to go through the nominating committee first. And then we have the staggered 6-year term, so our terms can overlap with different administrations and different parties. So we are independent. We are not in the executive branch. We do not report to the governor. There's oversight, obviously, through the budget process and through the legislative process, but the administration is not involved in our decisions. They do not opine on our processes or any deliberations that we have going on. we're what's called quasi-judicial or court-like, and that some of our processes, we're voting on what people should be able to do. And I'll talk a little bit about what those things are and what the meat is of what we do after I describe kind of who we are. We have a staff, it's down the street at 144, 27 staff members. We have a budget of about $8 million, which has been level funded for, I think, the last several years. And that supports the staff and the operations. Last year, we had a $4.1 million one-time appropriation for some sustainability work that we'll get to a little bit later.
If I can just, real quick, sorry. So we had VPQHC in here earlier and they talked about they get paid via a bill back. Part of Green Mountain Care Board is also paid via a bill back, and that's in statute. So just want to throw that up to everyone.
That's right. So we enter time for any regulatory process we do when we say, this ACO or this hospital, and then it gets billed back to whoever we're working on. I think the split is 60-40 government funded and general fund and industry.
Bill back, yeah.
Yeah, bill back. Our staff is multidisciplined. We have experts in hospital finance, accountable care organizations, certificate of need, healthcare policy, and data and analytics. And the staff is extremely impressive. If they weren't so nice, I would be very intimidated by them. But we have a number of staff members with advanced degrees that are relevant to our work. We have advanced degrees in public health, statistics, data science, epidemiology. We have 4 attorneys with JDs on our staff. We have a community development and applied economics PhD. And so these folks really have an educational background that helps them work on the issues that we face, and it can be very complex. And so the board members, 2 of us are from here, Robin and I. The other 3 have made Vermont their home and been here for a long time. And we're from 3 different counties, Addison, Washington, and Chittenden. You can go to the next slide. So we have Act 48, and that gives us our duties. Section 9375 enumerates what we're supposed to do in our obligations. And Section 9371 gives us our principles and the vision of what we're supposed to do. That's the policy that we're implementing when we do our job. And the 3 main areas of work that we have 3 big buckets, as I think of them. We regulate major areas of the Vermont healthcare system, and I'll go through what we actually do on that side and what the major functions are. Second, we have data and analysis. We have 2 gigantic databases of health claims data and clinical data. And I'll talk about what we do with that data and how it's useful for Vermont. And then last, we work on innovation in healthcare space. And what that means, innovation, it means changing how healthcare is paid for or how healthcare may be delivered. You may have heard of the all-payer model or Act 167 or the new all-payer model we're negotiating. We do that with AHS, and we support them, and we negotiate with them, and we partner with them to try and improve the methods by which healthcare is paid for to make it more affordable. And that falls in this bucket under innovation. I want to spend just a second on what makes us a little bit unique in government, because the Care Board is unique in government. And that's some of our core values and how we do our business. I mentioned that we were independent, and we are truly independent, but not in the sense that we're not part of the state government. We are state employees, our paychecks are from the state, we're state employees. Transparency. Our transparency is kind of unique in that we are subject to the open meeting law, and that really means 2 primary things. First, all of our hearings and deliberations have to be in public. We have a space where the public can show up and come and observe and participate in our hearings. And we do them by video. So anybody, anywhere in the state who has access to internet can log in and watch our hearings in real time. The second piece of that is that we can't deliberate as a group other than at a public meeting, which is challenging sometimes because I don't know where anyone's coming from or what they're thinking or what their points are until I go on video and the public is there and I hear their views for the first time or what their positions are. So we have to debate with each other in public on camera and come to a solution or a decision on an issue before us. The third part of that is the public's involvement and engagement is really, really, really robust. So my first hearing, I was sitting there and you can see who's popping up on Zoom. And there's all these people and all of these names. And I'm like, what are these people doing? Who are they and why are they here? And then we get done and I have to call for public comment and all these hands start going up. And I can tell you some of the points that are made when those hands go up are some of the most important points that we hear all day. And so that the public can show up, participate, and share with you what they think while we deliberate is just a really, really incredible feature. Not only that, but we have public comment periods where people can send in written submissions for us to consider. In Vermont, I don't know if this is unique in Vermont, but I find it amazing. There are all these people in your counties that have all this information on healthcare and all of these thoughts, and they're brilliant, and they want to share them. And so we almost have these like mini think tanks spread throughout the state that work together on their own time to inform us, and probably you guys as well. And so that's a cool thing, and I find it extremely valuable. So you get the letters, they can public comment in real time while we're doing our work. They can review the videos and send us letters. If you've ever read Digger, there's a lot of commentary that people put in and spend a lot of time on healthcare in Digger. So it's just a very robust engagement. Beyond that, we make a pretty concerted effort to make sure we're meeting with people and speaking with people and hearing Vermonters' voices. So I'll give you one little anecdote from my past life where, you do a case, you're convinced you're going to win. And then the other side goes and you're just like, oh my God, we are so toast. And my point with saying that is it's true. If you only hear one viewpoint, only the industry's viewpoint, or only this viewpoint, it changes your thinking. And so we have an incredible ability to balance the voices that we're hearing through our process. So I find that to be one of the most enjoyable parts of the job. And they don't always like you, and that's important too. It's important to hear it and see it, and everyone else to hear it and see it. The other piece that's important here is the healthcare advocate. I understand you guys have met with the healthcare advocate. They are an integral part to what we do. They have an office, and they have lawyers, and they have policy people, and they are a party to a lot of our hearings and what we do. So they have a right to attend the hearings and participate in the hearings. And again, we have 5 board members with views, we have staff, and then the public advocate comes and has views and thoughts that we hadn't thought of a lot of time. And they can be policy, legal, just consumer perspective, what our decisions are doing to Vermonters, the affordability challenges people have, the underinsurance issues. They are the voice of that side of things. So incredibly important. We also meet with them and speak with them and hear from them. Representative Black.
I'm just wondering how the healthcare advocate's role is any different than any other member of the public that would have access. Do they have any responsibilities other than coming and making comment?
Do you want me to jump in?
Sure.
So in some of our regulatory matters, which we'll go through in a moment, the legislature has indicated that the healthcare advocate is an actual party. So public comment, so they have the right to put in evidence, to ask questions, to participate fully in the proceeding. Whereas, obviously in a quasi-judicial court-like proceeding, general public isn't a party in that same sense, but they're at the same level as industry.
Okay, thank you.
Julia, we can go to the next slide. This is a little bit more on the public engagement and transparency. Last year, we had 52 public board meetings. That's one for every single week. I mean, we did take weeks off, but we have a lot of public meetings. And one thing we're doing now with some of the COVID issues, hopefully abating and continuing to abate, is we're going out and having what we call traveling board meetings, where we go to the communities so that we can meet with people and see healthcare being delivered and hear from the practitioners and the patient voice. So we had one last in December 5th, I think it was, down in Rutland. And the board members went out together to different places to hear the experiences of practitioners on the front lines in that community. And Representative Goldman attended that hearing that we had there.
I think Art was there too.
Okay, sorry, I didn't get to meet you there.
I was the guy with the bag over my head.
And Representative Donahue was there as well.
I saw her, yeah. I usually bring the bag just in case. So Robin and I went to a treatment facility, learned about how they're treating folks that are dealing with substance abuse challenges. And it's really illuminating to see how they do it. It's incredible some of the words they said. I said, what happens if you get a large influx in patients? She goes, we'll find a way to handle it. They have a real can-do attitude. And they're saying there's people who do and people who tell you why they can't. And that place tells you why they can, and they do it. So it was cool. We also went to the emergency department and also to a transitional housing place. We saw all various types of things, which we'll hear we don't regulate, but we learned about how regulation can impact it.
One quick question, Art, did you have a question?
Yeah, you had 52 board meetings. How many must you have, or is there no limit? Is it?
There's no minimum in statute, but so certain of the regulatory processes have timelines that are set forth in statute, and so those are really the must do. But in order to ensure that our work, and Owen will talk about this in a second, is really informed by a broader set of issues outside of the regulation, it's helpful for us to have.
Sure, no, I understand. I didn't know whether those, and I forget whether you had an agenda in Rutland or not. I think you did. I
We
think
did,
you went
yep.
over
Yeah.
some things and voted and did all the things you do in a regular meeting.
Yeah, since
I didn't know how many were like that versus just informational, that's all.
Yeah, I would say most of them are actually more regulatory focused. That would be the category I would put most of them in. And then we have community meetings like that and then informational. So those are probably the three types.
Yeah.
Yeah. And since the board's inception in 2011, it's always been pretty much weekly, at least once a week. So that's sort of been the culture of the organization.
Yeah, so we'll have some on important issues that Vermont's facing that the board wants to learn about. And so we'll call in local experts or national experts to tell us about issues or possible solutions that the board should be considering in our regulatory function. So next week we have an expert from the University of North Carolina who's a rural health expert, and he's going to present to us and share with us what he's seen nationally for rural health. And that will inform us and some of the things that are possible in connection with our 167 work.
And we plan on watching that as part of our community work. Yes.
Great, that's great. He's really impressive. We spoke to him this morning, and he'll be wonderful. Another one we've been working on is primary care. There's concerns about inadequate primary care numbers of providers here, and so we're digging into that issue to learn more about it. We had one in October, I think it was, and we're going to be having another one being scheduled fairly soon. So we'll have some local people share with us some experiences. So these are just informational for the community and for ourselves in our regulatory process. So those are, I guess, volitional, I guess I'll call it. Kind of similarly, we have advisory committees. One we're required to have by statute, the general, and then we also have a primary care and a prescription drug advisory committee. And they share with us issues that they're facing and challenges. So for example, primary care community will tell us about some issues with how our decisions on hospital budgets influence insurance rates, which influence what they have to pay in their practices and the challenges they face with reimbursement levels because they have challenges in that. So, can we go to the next one, Julia? And the next one, please. So I'll get into a little bit of the meat of what we actually do in those big three spheres. The first and foremost is regulation. Talk about regulation. It really involves part of the healthcare system, but it affects and touches all of it. So there's a number of things we do not regulate. This slide has that. For example, federally qualified healthcare centers, we don't regulate. And typically regulation means we're reviewing budgets and expenses or providing certifications or certificates of need. But FQHC has independent providers we don't regulate. Ambulatory surgical centers, although we will do that through a certificate of need, which we'll talk about. Out-of-state providers, Medicare and Medicaid, Medicare Advantage plans, and self-insured plans, which is a big issue here in Vermont. There's a lot of Vermont lives on self-insured plans. That just means that they fund the entire plan themselves as opposed to like Blue Cross Blue Shield, which is more of a traditional commercial insurer. And this is what we do directly regulate. Insurance rates, certificates of needs, hospital budgets, and ACO oversight and certification. Go to the next slide.
What does ACO stand for?
Yes, good question. I'm sorry, I should have. My staff has been so gentle with me in not using acronyms. So I should know better. It's an accountable care organization. which is really just a group of providers that get together to be paid in a different way and be accountable for the care and the cost and the quality of the care they provide. And it also resources, data resources, care coordination, so that providers throughout the state can have that without having to pay for it separately.
And in Vermont, our accountable care, the only one we have right now is OneCare. Well, we have two, right? Medicare One started, right?
Yes.
Yeah, so go ahead, if you can just real quick,
Sure.
who it is.
It's
Lower Health.
Lore Health, they changed the name. We certified them in October.
Lore?
LORE.
They're a small Medicare only, they only LORE.
Lower Health.
They have one FQHC practice in their ACO right now.
Oh.
Very small.
Isn't that the name of Data's brother in Star Trek?
Okay, we're gonna stick to the.
Because he ultimately knew.
Let's keep going.
So this is our regulation in 2022. We had 14 hospital budgets that were reviewed, 2 accountable care organizations, had 11 insurance premium filings, and 7 certificates of need. Just real briefly, a certificate of need is an application that's submitted to the care board where an entity wants to do something, a capital investment. They want to spend money and build something. And so they submit the application to us. And it could be for a surgical center, a new dermatology practice. It could be for a new MRI machine. There are certain thresholds that trigger the requirement for the submission. But then we get it and we evaluate it. And some of the things we look for is like, what does it cost? And what's the demand and the need in the community where it is? And is it appropriate? And by that, I think we mean really, we're trying to make sure that resources are distributed fairly throughout the state. So there's not every MRI in Burlington and none in St. Johnsbury. So that's something that we're looking at. Affordability, need, and fairness and equity and where we're allocating these resources. And then the board votes on that and makes a decision on whether or not the entity that submits it can go ahead and spend the money to do it. And right now, you've probably heard, but we'll touch on it, some of the hospitals are having financial challenges. And so certificates of need are spending more money out of their capital. So that's something that we're considering in these decision-making processes.
All the hospitals are handled independently of one another. Like you just mentioned, and that was kind of my original question on the purchase of a piece of equipment, an expensive, large piece of equipment. And you mentioned that, Burlington doesn't need 3 when St. Johnsbury doesn't have any. Independent, I mean, maybe you can say that, okay, you don't need one, we're gonna shift it to St. Johnsbury. I mean, are those things doable by you? I mean, can you? No.
So in that, yeah.
Not in the certificate of need process for sure, no.
Okay, and
Sorry.
it seems like, if a hospital says they need a machine, it would seem that they're the experts. And your role, I know you're looking at a lot of things. I mean, do you typically approve of what is asked when it's something big? I mean, you may not have any knowledge of this yet.
I've only done a handful.
Yeah, so historically, I would say that the certificate of need process has acted as sort of a gatekeeping process for entities to think about whether the piece of equipment or the building or whatever it is needed, because they have to come in and show the need for it. If the entity comes in and shows need, which typically does happen, I think all of the certificate of needs that I've seen in the almost 6.5 years that I've been there have been approved. Where I think the process adds value is that in other states, you see proliferation of new buildings and new entities coming into the market without any consideration about whether that capital expense, which does get passed into insurance premiums, so everyone's paying for it, that can happen unchecked a little bit. And so in a state like Vermont, where we don't have competition, in healthcare because of our rural nature and our small population. It adds sort of a gate. Often what we'll do in our decisions, though, is we'll include conditions. So sometimes those conditions might add transparency. So for example, if an entity comes in and says, we want to offer this new service, but we only want to offer it to commercial patients, we don't want to offer it to Medicaid, we may add in some conditions around ensuring that it's accessible to everyone, or reporting if there's some concern about a particular aspect of their application. So it gets really weedy really quick, but that's really been the focus of the Certificate of Need program in particular.
Okay. All right.
And the other thing we should say, and we won't go into the weeds on it, is that there are jurisdictional thresholds. So if it's under a certain dollar amount, we don't look at it.
You don't look at it.
Or if it's a routine replacement like of a boiler, we don't look at it. So we came in a few years ago for a change to get rid of some of the things where we really didn't feel like we were adding any value. Like, I don't need to look at somebody's boiler replacement. That doesn't really make sense, right? Like they need heat at a hospital.
Right, I assume it's mainly, medical need more than anything.
Yeah, I would say most of the CONs have either been very large capital improvement, like new buildings, or big renovations, like $30 million renovations, like big ticket items, or we actually had for a little while a number of substance abuse new substance abuse entities coming in. And those usually get expedited because there's such a need for those services.
Okay, we have Joe and we have Maury, but then I just want to keep us moving along.
If this will occur in another part of your presentation, please feel free to let me know. But I'm curious, when you're acting in your quasi-judicial capacity, what are the standards that you're using for review when presented with whether it's a certificate of need or ACO oversight or whatever it is? Are there statutory findings that you need to make or statutory standards that you need to meet in order to make those decisions? Or is it more based on your own personal expertise in the area?
Good question. It is laid out in statute for each of the processes. So for example, we just went through the ACO, the Accountable Care Organization, and there are I forget how many, 15, 17 different factors that we weigh and evaluate in terms of so it guides what we're supposed to look at. The other part of it is there is a standard, and it is an ACO's burden, for example, to satisfy us that their budget is appropriate for their operations. So there are standards and there are factors that we're directed to look at and consider.
And that would be found in
Title 18.
Title 18.
Yeah, Chapter 220.
Chapter 220, thank you.
All right.
And you can find the certificate of need process online, right, on the Green Mountain Care Board page. I was just going to mention one notable, I can't think of the word, was not accepted, an application by Fletcher Allen was before you were on
before my time,
to sell their outpatient dialysis clinics to Fresenius, a major multinational dialysis corporation, and that was denied. That's the only one that I remember.
There is, I think Robin alluded to this, but there is also value in the process. I don't think people are going to be submitting them if they don't think they're going to hit the standard. Right. So hopefully there's a gatekeeping function like Robin said to that.
Great.
All right. We can go to the next slide, Julia, please. Just to give you some sense of the numbers involved. Last year, the system-wide hospital net patient revenue, that's the main data point that we look at, was $3.27 billion for our 14 hospitals, which was a 10.22% net patient revenue increase over fiscal year 2022. So how a hospital can hit the budget. There's a number of ways they have revenue, but the primary ones are what patients come, how many come, the mix of care that they're giving, and what they charge and what patients pay for those services. So this expense can translate through to your constituents. When we have a big increase, you then see insurance premiums go up. There's a relationship between those. And this is really the biggest issue, affordability, sustainability, access. They are in competition with each other. You have a situation in Vermont where the hospitals are Their days cash on hand, which is a measure of health, is going down and has been going down, other than a couple of years with some federal funding help in connection with COVID. But it's been a downward trend with days of cash on hand. And the operating margins, another key data point we look at, has been declining and now are negative. So usually operating margin is where a hospital gets money to fund projects. And so when they have negative operating margins, they're in difficult positions. At the same time, so you have difficult finances and you have difficult Vermonters' finances. These costs are borne very heavily by commercial insurers and payers, the Vermonters who are paying for the insurance, and the small businesses. And so we want sustainable hospitals. We want hospitals to be financially healthy. We want them in the communities getting the services they need, but we have to pay for them. And so that's the challenge. So in Vermont, we have huge volume right now, incredible wait times to get in to see doctors. At the same time, we have very bad finances and they're very expensive. So we hear a lot from folks who are concerned about what they pay for insurance. And I pulled one data point. Insurance costs are very complex, so this is not the be-all, end-all number. But for a sense, a silver plan, which is the gold, silver, platinum, silver, not the highest level plan. They have high deductibles after you go and get care.
I'm just going to say this is qualified health plans, which we have not gone into the silver levels, and we're not going to go into that now. But it's a
sense for a family on a silver plan on the exchange without subsidies. There are subsidies that make these cheaper depending on your finances. It would be around $2,000 per month. And if you take the average income of your households in your communities, $2,000 a month, if they don't have subsidies, is a lot of money. It's very, very, very significant cost. So we're not able to just continue to just charge more and more money through the commercially insured payers. The other part of this slide I wanted to talk about, we mentioned a little bit earlier, but in connection when we have a hearing, we have those parties. I should have done some bubbles, but you have a regulated entity, a hospital here. You have their written submissions. You have their testimony. They come and testify. We ask them questions. You might provide written answers to interrogatory questions. Then you have us kind of in the middle, the five of us with the staff sharing information with us before and at the hearing and after the hearing. And then you have the Healthcare Advocate's Office who's providing information. And then you have the public comment. And then you have written public comment. So we're taking in all this information up from the staff, across from the regulated entity, from the Healthcare Advocate, from all of the public. And then we look at those factors and standards and try to make the best decisions that we can, guided by the principles of our statute, which are affordability, access, and quality. It's not
easy.
Easy peasy. Yeah. And anything you do, the other sides of those things has a lot of opinions and views on what you did, which are important to hear. We can go to the next slide. I'll go a little bit quicker since this is.
We're good. I mean, I'm gonna hold questions, I think, for now. We're not gonna stop at 2. I wanna hold questions and write them down if you have them, and we'll make sure there's time.
So an insurance rate review, that's when the insurance companies come and they submit submissions to us on what their rates should be that they're going to charge. It'll often be like how much more they're going to charge. And so we get those, we evaluate them, again, guided by those principles, affordability, quality, access, and we have to make our decisions. There's certain things we can look at within those submissions where there may be room for efficiencies, where we can save money, where we'll challenge things, we'll see if we can make it less expensive. But again, we need our insurance companies solvent. We can't cut out all of their revenue because they use a lot of it to pay for the care that Vermonters need. So you can't have them insolvent because they're going to get claims, and a lot of claims. And there are increasing costs. So we have to consider all of these things. I just want to give you some sense of the decisions from last year. And with COVID, things were obviously a bit turbulent. There was a drop in the volume of patient care during COVID because people didn't go to the doctor for regular things. So there's pent-up demand. So costs went down, and then the demand came back and it spiked up. So some of these numbers reflect that dynamic that we had here in Vermont and across the country. MVP, individual plans, they requested 24.4%, the board approved at 19.3%. That is a big jump in money for payers, 20%, that is big. Blue Cross Blue Shield, they requested 14.9. The board determined 11.4 was more appropriate. And you can see the small group plan numbers as well. The ACO oversight, the Accountable Care Organization, we touched on that briefly. There are 2 in Vermont. We went through the large one, OneCare, in October, November, December. It has a series of hearings on these issues. And the board approved their budget with a financial modification and a number of requirements. And we're now doing some more guidance for that ACO on what the board would like to see that's necessary for them to do in this coming year. During that process, there was a fairly large change. Under the all-payer model agreement, there's 3 main payers: commercial, Medicare, and Medicaid. One of the large commercial payers, Blue Cross Blue Shield, wasn't able to execute a contract with OneCare for this year. So they pulled out for this year, and there's, I think, about 90,000, 100,000 lives. So a big number of people. And that was something that we had to consider. And we're still considering, as there's going to be a resubmission of a budget to evaluate the change in that situation.
We're going to hold questions. We're going to hold questions for right now. Thanks.
Again, the healthcare advocate is a party to these processes as well. Go to the next slide. We touched briefly about this, the certificate of need process. Gave you the numbers of how many we reviewed. And just for a sense, Representative Peterson, I think you were asking, the amount of money involved in all of those that we reviewed last year was around $50 million, so a fairly substantial amount of money. And we can go to the next slide, Julia. The second big bucket of work that we do is data and analytics. And I think this is one of the neatest things we do, but you need to kind of get some examples to really understand what it is. We can come back, we can answer questions. I'm not going to get too weedy into all the various aspects of this, but to me, the big 2 pieces are what's called VCures and VUDs. And those are just databases that we have. There's 2 of them. VCures is what's called claims data. And a claim in healthcare is when you go to the doctor and you get a procedure, they submit a claim to your payer. So I get a primary care checkup and they send a claim to my insurer, I think it's Blue Cross Blue Shield, and they pay the claim. And that's a claim. And so this database has all of the information on claims that are submitted throughout Vermont to the different payers. And then VUDs is what's called discharge data. That's clinical data. And that gives you information about the treatment and the services that were provided, how long a patient was there in treatment. And this is important. If I can give you some examples of what we've done with that data. There's a wait times report that DFR did on how long it takes to get care in Vermont at various types of specialists. And that information that fed that report was the, I think it's a VCures database. And so we had heard, people have heard in the Vermont community, lots of stories about not being able to get in to see your doctor. And so you can hear one-offs, but you need to verify it before you take legislative action or policy action or regulatory action, right? That's important for us to know when we're seeing all these certificates of need. Is there a backlog in getting to a dermatologist or an ortho or whatever it may be? So we tap that database and understand the problem and verify it. And that really helps us make better decisions as regulators, as legislators, policymakers, practices everywhere. And the other example that I really like that we use the data for was suicide risk. We've had a real challenge in Vermont with mental health. And so we used some of the data that we have to understand some of the interactions that people had prior to suicide incidents. So you can see trends in what's causing and impacting some of these things. And it helps us better understand what interventions in the medical community are helping stop that problem. So extremely robust, granular, valuable data for legislators and policymakers in the entire state to have this. The last one, which I really thought was interesting, was there was a lung cancer study that was done. And what that was looking at is outcomes with lung cancer and correlations to socio-demographic situations and rural versus urban folks in Vermont. And what was found was that folks in rural areas waited a lot longer to get treatment for cancer. The outcome, of course, of that was a much higher mortality rate. So we as regulators and everyone else now understands that that's an issue in rural communities and something we can actually solve, right? So this data is extremely important to what we all do, and it's tapped frequently, and we have an excellent data team. We can go to the next slide. I go on the website here and there and just kind of float around on our data website on the board. This is an example of it, and there's many pages of information, but I just want to give you one sort of screenshot. You can just, in a real live setting, hover your mouse over this. You can get information about who the top payers are and how many members they have. So we can see how many commercial payers there are. How many lives that are paid for through commercial insurance. How many are Medicaid, how many are on Medicare, and how those things are changing over time. And there's other data about how many are self-insured or on regular traditional insurance. You can see what's going on in our community. Can you go to the next slide? This is just another example. I think this is from our health resource allocation plan. And on this, you can go to your community and hover over Newport, for example, and then you can see how many physician assistants you have in Newport per 100,000 people, right? You can see how many primary care providers you have in your community per 100,000 people. It'll actually give you data on the low for the state, the median for the state, and the high for the state. So you can see what resources your community has relative to everywhere else in the state. So this one that we pulled is just the physician's assistants, but you can also see percent of adults who cannot obtain care or have delayed care. You have the percent of people that are what's called underinsured, which means they don't have sufficient insurance. And you can just click on this and go to your community and see the stats, which is an incredible tool. I encourage you to do it. It's fun to look at. Sometimes it's horrifying to look at, but it's really valuable stuff, I think, for you guys to have. And then there's all kinds of information on expenditure, the spending, what we pay for healthcare. So here you can see where the money came from. Health insurance was 83%, out of pocket is 12%, other government 4%. And then you can see within that pie of health insurance, how much of it was commercial, Medicaid. And then you can see where it goes. So where is all of our healthcare money? It's what, $6.5 billion, $7 billion? And you can see here, 35% of it goes to hospitals. Let's see, only 4% to nursing homes, 14% to drugs, 2% to home health. So you know, a lot of healthcare, when you have a limited amount of money, it's an allocation problem. And here in this data, you can see how we're allocating it and using it, our resources.
And those links below take you to this.
Yes.
Resources, right? That's great.
Yep.
Thank you. You know what, I'll take I think we'll break right here for 1 second. Are there any questions to anything up to date? Okay.
And I don't know if you're gonna be able to answer this today. It feels like a big deal to have Blue Cross Blue Shield lead the ACO, and I'm trying to understand, like there's some Medicare, there's requirements from the federal government that led to the creation of the ACOs. So I'm just curious, how does Blue Cross Blue Shield fit in? Like, maybe this is a question for them, but it's like, how do they meet those requirements, and what does it mean for the solvency of the current ACO? And also, like, maybe I missed something, but I never heard of LOR before, so I'm just curious what that's about. So if there's no time today, it's fine, but these are some things that I would like to learn more about.
And we will, I mean, you can comment, but we will be digging into this later in the session.
This is it's very concerning, actually. It's like it sounds very unstable.
There was, and I just also want to say there was a request from the governor's office for the parties to continue talking. So they're doing their work, which they need to do. And I recommend that you go on the Green Mountain Care Board website and look at the requirements that Green Mountain Care Board put on the ACO's OneCare's budget. And then they'll be coming back, obviously, with a second submission to deal with if there's no agreement between Blue Cross Blue Shield and OneCare. So if you want to comment, great. I don't want to spend a lot of time on it because we'll come back to it.
It's a really important question, and it is, I guess I'd characterize it as a big deal in a lot of ways.
Yeah. Thanks.
But at the same time, I'm hesitant to comment further than that because it's an issue that's before us currently.
That's fine.
So I just want to be cautious about that. And there's been some press about it, but I don't think I can comment right now, just where we are in the process. We are going to have hearings on it pretty soon.
So all in good time.
Yes.
Yes.
Definitely.
But good.
Anyone else have any questions?
Just a quick one. In terms of the hospital's stability, people like myself can't afford the cost of healthcare. What kind of statistics do you have in terms of that all the hospitals, the impact of that on their stability? Is that a big deal? Is that the biggest deal?
I want to make sure I got the question right. What impact is?
People can't pay, so they don't have insurance. The hospital has to serve them anyway. So what is the impact of that? Is that
I think
impact or what?
I couldn't categorize it. I think it's a good question. It's significant. I mean, the hospitals have a lot of care that they have to write off because people can't pay for it. How much that is, I have not been through a hospital budget myself, so I don't really have a good sense.
Yeah, I don't have it off the top of my head, but we can pull that for you, Topper. Each hospital in their budget, when they submit it, they have a line for bad debt and free care. So, and also in their reporting on their actual expenses, we can see what that is. That is factored into their their hospital budget as a whole, so that think of it really as an offset, right? So if they're asking for this amount of money and this amount of expenses, you have to make sure then that that bad debt and free care also is factored in. So it is included. I think we're fortunate in Vermont that we have a very low uninsured rate. So I think that doesn't mean though that folks don't have trouble paying for their deductibles and that sort of thing. So we can pull those statistics if you'd like.
And Roz will be in next week, I think. So that would be a good question for them too. Great.
Just keep going. I think the next section is on that third big bucket of what our work is, which is what we call innovation. And I'll let the expert on healthcare innovation speak.
Thanks. So there are three real buckets that we focus on innovation in our work. The first is around hospital sustainability. So I'm going to come back to that one because I'll kind of walk you very briefly through the history related to hospital sustainability and what kind of led up to Act 167, which I know you briefly touched on. The second is the Vermont All-Payer Model implementation and reporting. So I believe you're hearing next week, getting your deep dive on the All-Payer Model.
Yes.
So you'll learn more about what that is, but in a nutshell, it's an agreement between the state and the federal government, the Center for Medicare and Medicaid Innovation, to allow for Medicare to participate in Vermont's ACO program. And it allows Vermont to have certain flexibilities that aren't available in the national accountable care organizations programs that Medicare runs, meaning that the state has a little more influence in terms of framing how that program works. So we can tailor it a little bit more to Vermont. Our specific role is as a regulator, we step into the shoes of Medicare to work on some of the details of the Medicare ACO program, like their trend, for example, is a decision point that we make. And we're responsible for reporting on the different metrics that are included in that agreement with the federal government. And Brian actually alluded to one, which is something called a scale target, meaning the state has made certain commitments about including a certain number of people in this model. On the scale targets in particular, they were very, very ambitious. So spoiler alert, they were very ambitious. We have not met them. But the federal government has said, hey, we recognize these were not realistic. There were some technical issues that were not understood at the time of the agreement. And so they've basically waived that for now. So just to address Brian's question about Blue Cross pulling out, I wouldn't anticipate that will create a problem under our reporting our responsibilities for the all-pair model from that one perspective. Not that it's not a big deal, but at least in terms of the federal relationship, they recognize that there's issues with scale. So our staff is responsible for doing that reporting to the federal government. All of those reports are on our website. And I don't think it would make sense for me to go into the weeds until you've heard more about the all-pair model. So if you want that, we can come back.
Thanks, Robert.
Owen already touched on our advisory groups, so I won't go into a lot of detail there, but basically we form ad hoc advisory groups plus our general to inform various issues or problems as they come up. He talked about the primary care advisory group. Another new advisory group that we're going to be starting at the end of the month is related to the Act 167 work. So Julia, if you could go to the next slide. Let's turn to that because this is a big piece of work that we have moving forward. And Owen mentioned when he was talking about our budget, we got a one-time appropriation of $4.1 million to support this work, understanding that that appropriation was a multi-year appropriation, meaning that we'll be carrying over funds year to year because this is a big project. It's not going to get done in 1 year. It's probably not going to get done in 2 years. It's a big project. So the way we got to this work was, Owen mentioned, we've been seeing issues with hospital margins declining and their days cash on hand declining. So in 2019, the board became concerned about the financial stability in general. And so we held a panel of national experts to come in and talk about that because this isn't just a Vermont problem, it's a rural state problem. So all over the country, and you'll hear this next week. So this is a little teaser for next week's board meeting. There's been a couple hundred rural hospital closures in the United States. And though we're not immune from those dynamics. So we had this panel, we realized we needed to do some work on it. The legislature charged us with convening a rural health services task force, which was a bunch of different stakeholders. We pulled that together. I chaired that task force, and we came back to the legislature the next year with a number of recommendations, many of which you pursued and adopted, particularly around workforce. But that work really then led to Act 167, which is really providing the board with work on three different fronts. One front that we are leading is a community engagement process where we will be moving forward and talking with all different areas of Vermont to talk about these hospital sustainability issues and try and figure out how are we as a state going to address this so we can ensure people have access to what they need in their communities, but at the same time can still afford their insurance. That work, the very short update is that we're in the contracting process. We need contractors to help us do that. And we can come back and fill you in about more details about how that's going, but we're in the middle of that process now. Another major stream of work there is looking at hospital payment reform. So how do we move forward with changing the way we pay hospitals to both ensure that they have more predictability, but that our cost growth is on a sustainable track? Costs continue to grow, but how do we ensure that they're an amount that people can afford over time? Related to that, we are kicking off, in collaboration with the Agency of Human Services, a global budget technical advisory group that will look at hospital global budgets, which is a payment mechanism which has been used in Pennsylvania to stabilize rural hospitals. It was used in the 80s in Rochester, New York, and is also currently used in Maryland. So we're going to be really getting into the weeds and figuring out if we were to move forward with this type of payment in Vermont, what would that need to look like? What are the technical details? And then the third stream of work is a stream that AHS is leading that we are collaborating on, and that is looking forward to when our current all-pair model is concluded, which will be in 2 more years, the end of 2024. What does that next model look like? And they're taking the lead on the negotiations with the federal government, and we support and work with them on that as the regulator. And so in all of the states where the federal government has had these kind of agreements like we have, which is us, Pennsylvania, and Maryland, They usually have 3 parties in that agreement: the federal government, the state governor, often the state Medicaid agency, and 4 parties if you count the federal government, and then the regulator. And that's because they want to ensure that all different parts of the state are working together and are in agreement, because of course, if you have, different parts going in different directions, it won't be as effective. So those are really our major streams of work around innovation. They all really come out of our regulatory roles and work day to day.
It's big work. I mean, and for those of us that were on the committee last year and passed this out, it was a lot of work. It was a lot of engagement with the stakeholders. And I've talked to Senator Lyons, and we'll start having some updates and, make sure we're moving along, because it's important.
Yeah. And then I think I'm turning it, Julia, you can advance the slides, and then I think I'm turning it back to Owen.
So just a couple other quick things we just wanted to share where we're focused on our work in 2023. We just talked about the sustainability. That is a big piece of what we are focusing on this year. We're also engaging in what we call regulatory process refinement. And what that means is we've been around for 11 years. Some of our regulatory things we do have evolved, and we're continuing to evolve them. We're trying to make them better so they're more predictable, and we get better data that evaluates performance of who we're dealing with. So for example, we want better measures and clearer measures on performance, cost efficiencies, so we can have better opportunity to make it more affordable. And additionally, we're trying to lower the administrative burden that we put on hospitals when we ask them to submit this. They're huge binders. It's a lot of time for them. It's a lot of money for them. And that money comes out of Vermonters' pockets. So we need to do some self-reflection on how we do our function so we can serve Vermonters better. And we're doing that right now. I think we're in the process of interviewing all of the hospital CFOs to get their views and feedback, but we're going to engage with the hospitals and others to, again, get both sides of how we can do our work just in an improved way. We're also working and continuing to collaborate with AHS in the negotiation with CMS. And then we're going to be doing some panels that will inform us of some of the major challenges Vermont's facing in primary care. One I mentioned earlier, we're going to do probably some work around affordability to get a sense to Representative McFawn's question about what does this look like, what does it cost. We want to do a deep dive on what the impacts are when you see a 20% rate increase on our families and our communities. We need to have that piece really front and center when we go in and start looking at all the budget requests that are going to come in this year. And then we're also going to be looking at some issues with what's called transitions of care, which is making sure that patients are in the right place and getting care where they should. So we talk about resources, right? You have primary care, long-term care, mental health. A lot of this work is getting concentrated in emergency room departments. And that's because we don't have those other pieces of the pie where people need to go. So people need to get care in the right places because 1, they get better care there, or 2, it can be much more affordable or preventative, for example. So that's something we're starting to talk about and think about and trying to see if it's something we can dig into. So that's where we're focused this year. It will evolve. Healthcare seems to move fast and exceedingly slow. So
it does, all at the same time.
In the next slide, I just wanted to share with you all, I know some of you are new. We have a lot of legislative reports that we've done at the board that are on our website, and I wanted to provide you some information about what some of those are. You can see what the reports are here in the left-hand column, some of the dates that we'll be submitting them this year, and the statutory legislation that requires us to submit them. So we have one coming up that I'm going to go continue writing as soon as I walk out of here, which is our annual report, which is due the 15th, but lucky for me, we have a holiday in the weekend. And so you'll see that on Tuesday.
Great.
We
Anxiously awaiting it.
Yes. We also have our expenditure analysis, ambulatory surgical center reports. You'll see there's a whole number of things that are coming up fairly soon. And the next slide.
Can I ask a question? on the slides, this is for our scheduling purposes, is the update on Act 167, will that be to us on the 15th?
I think actually Sarah is trying to submit it today.
Okay,
It
great.
might be Tuesday if
That's fine.
something's gone awry and back at the office, but I think she was hoping to submit it by the end of the day.
Okay, that's great. Thank you.
And then the next slide. These are, again, some other resources, which are public board meetings. You guys can watch any of them that you want at any point in time. They're all on Orca Media. There's links on our website, so you can find ones. If there's topics that you're interested in learning about, you can go and see experts talk about it. You can see a process just if you're interested. The public comments are on our website, so you can see what folks are saying and thinking and feeling about some of the issues before us. And then we also have the sustainability reports and a number of other public reports and analyses that are just on the website. And we can help any representatives find anything that they're looking for. Rare times, bless you.
Thank you.
Where we also prepare reports for the legislature.
A lot of times. Reports for the legislature.
But so that means we have a lot. So if you need things, we can get them.
Great.
That's all we had for today.
Great, that's wonderful. I think we'll open it up to questions if you still have time. Great, Leslie?
I can't remember where this happened. Was it in 167 or someplace else about simplifying your website and making it more accessible? I don't know where that stands, but I, for one, find your website a little hard to navigate. So I don't know if you want to do a tutorial, or which would be wonderful, or how it could be more accessible. So I don't know what you, yeah.
I don't know if we did anything on the website. I think we requested reports be done. Report summaries for all the reports that come out is what we put in legislation last.
But I remember talking about the website at some point. I don't know if you remember that.
It's certainly something we are always striving to improve. I can certainly say that. Quite frankly, it's not really a staffed position. So we're always working on it a little bit at a time as staff have sort of free time to do it. So it takes a long time because it's not like it's somebody's job to maintain or improve the website. So that's part of the challenge, just to be frank.
Well, I would think as a public facing thing that it's not, I don't find it friendly.
Yeah.
I don't
I hear
either.
you.
Oh, good. I wasn't sure it was me.
I know where everything is at this point.
Right,
Yeah, I mean, you're a deep user, but I'm not. And
I was new to it this summer when I was going through the process to apply for this position, and I found it difficult.
Yeah.
One thing I forgot to mention, which might be useful to new members, is we have one-page explainers on some of the things we do, and a lot of the acronyms are translated and put in plain English as to what they are. We can send you links to those or get them to you.
If you can send those, they are I was going to bring that up. They are very helpful, just a quick read to understand more of what the Green Mountain Care Board is. If someone could send them to Claire, would be great, and Claire can pass them around.
Great.
Thank you. Joe?
Thanks. In asking this question, I very much want to preface this by saying I very much heard what you said about that, if our insurance companies become insolvent, claims occur, claims don't get paid, the system collapses. However, I look at, in some cases, up to nearly 20% increase in premiums, and that terrifies me personally. It also terrifies me for my constituents. And I realize that we are in a special and difficult moment when it comes to healthcare, with the pandemic and recovery from that, and everything like that. And what I've heard from you today, and what I feel like I've heard from many organizations that have come to us, is that you were trying to figure out the affordability piece. How can we make healthcare more affordable? But in my experience, that when prices go up, they never come back down. And so I guess my question for you is, if we are to be successful and we are to make a more affordable healthcare system, is it possible if for, any of these organizations, MVP, Blue Cross Blue Shield, whomever it may be, comes to you in 5 years and requests another, 10% increase over what they got the previous year, and you've determined that healthcare costs go down, could you actually say no? Could you actually say no, you're getting a negative increase? We're actually going to drive down your premiums because we figured out the affordability piece. Is that at least theoretically possible?
Yes, it's theoretically possible. I've seen it once, actually. I've seen it with one insurance filing in 6 years where it was a negative. The insurance filings are trued up based on actual experience. So if the actual experience used is greater than it would be for the next year, then it would go down. So it is certainly theoretically possible. And we do a deep math dive with some experts called actuaries to kick the tires on the math that the insurance company has been doing and making sure that they're basing it on realistic trends and realistic data.
Thank you.
Yeah.
Art?
Yeah, the requirements and the ask from Act 167 for you folks to do what you need to do to make that come to fruit and to give us something that will help with sustainability. I look at that and then I look at what you said, Owen, about all your meetings being open meetings. What opportunity do you have to look at this stuff? Is it always an open meeting? Is it always with all five of you, with people's that it just doesn't seem productive if you're going to get anything done that you have to be in that environment. And can five of you meet in a room without legally with?
So, yeah, I may be overstated.
Okay.
The answer is we can all be together, but we cannot talk about a matter that's before us for a vote or a deliberation. So we
Unless the
can't.
statute tells us we can, right?
There are some that we can, right?
Yeah.
But a number of them we can't. So,
Okay.
yes, we can all go get lunch. We never have. I think
That's noted. We're noted.
But now that I say it, I would really like that. But we have administrative board meetings and we have attorneys that we call them whistleblowers. And they stop us if we ever get close to anything that's a deliberation
Okay,
of something
yeah,
of
yeah,
substance.
yeah, yeah.
And on your question about the negotiations with CMMI, what we typically do is we will have 2 board members assigned to something. So the other 3 are not part of it.
Okay.
And 2 can go and work on an issue together. So
Because I imagine you're going to have a lot of that.
Yes.
Yes.
You're going to have a ton of it
Yes.
to
Robin
get
and I-
this done.
Yes.
Yeah.
Robin and I are meeting with Secretary Samuelson and her team weekly, bi-weekly, more frequently
Yeah,
on some of that
okay.
work. We traveled together to work on some of the stuff, but the other members aren't part of that. We're not deliberating on the vote of whatever the next thing is.
And you have contractors already that are working on this, or are you going to get them? I know
It's a mix. So for the all-pair model work, AHS has a contractor that they have on board. We have a contractor on board for the global budget subgroup work that I mentioned. We have 2 contractors on board. For the community engagement, that's the one that's still in process. So,
Okay.
there are different stages, and we can kind of go over that if we come back for a deep dive.
Yeah, right, okay, I don't want to go into
Yeah.
too many weeds. Okay,
Yeah.
thank you.
Leslie?
This question may be unanswerable, but I do wonder, and I have sat through some of the budget hearings this summer, what would we look like in Vermont if there was no Green Mountain Care Board?
It's a future I don't want to contemplate. I haven't really given that a lot of thought because I just got here.
Yeah.
But I think
Way to go, Leslie.
Well, it comes up because people say big bad Green Mountain Care Board. So I just wonder, what would we look like without it? I mean, I'm really impressed with the work that you've done. And I've seen enough of it to have that be reinforced, but I don't know. I was just wondering.
So I think part of it is how we do our work. And I think that's really one of the things that makes it unique. Is it impossible to move the VCures data and the BUDS data somewhere else and somebody else maintain it? Is it impossible for people to go to some other agency and do it at an agency? No, it's not. It used to be done that way. It could be done that way, theoretically. The difference, I think, is the public aspect to it and the removal of the electoral politics, right? So we have regulated industries. Regulated industries have money, they have resources, they have lobbyists. And in some sense, when you're not up for election or you don't have to worry about campaign fundraising or any of that, you're a little bit removed and can make decisions. I feel more free making decisions I just think are in the best interest of Vermonters. So that's a big difference. And then second, the open meeting aspect of it is removed if you put it somewhere else. So I think there's some very important material differences in how the work is done. I also think it's really unique having 5 board members with different viewpoints and experience. We don't always agree at all. And that's really valuable as well. So I think just the public aspect, the transparency, the way we do transparency, and the removal of influence. So I have a soft guideline for myself that I meet with nurses, I meet with doctors, I meet with the healthcare advocate, I meet with businesses, I meet with patients, and not just regulated industry. I meet with them too, plenty, but we need a balance. And I feel a little bit more free to do that myself as the chair, because we get a lot of phone calls for our time and ear.
And I can just echo that from my lived professional experience where I worked for a governor and now I work at the board. And the political influence is very different. Like, I don't feel like I don't have to worry about the politics. I mean, not that there aren't politics, but I can make my decision based on the facts, the law, and what I think is the best decision I can make for Vermonters. And it's not influenced by party politics at all. And I can tell you, having worked for a governor, I was on the phone sometimes to DFR.
Daisy?
This has been just awesome. I've found this so very helpful. I have a ton of questions. I'm going to try to narrow it down to one, and it's around practice improvement. I think we often all hear a lot in here about, quality care and improving that, and, being patient-centered, triple aim or quadruple aim, as I believe in. And having a quality workplace for our healthcare workers. Can you speak a little bit to, under your innovation bucket, what you're doing to really lead the way in Vermont to us being a model for practice improvement and being a fantastic place for people to work?
Shall I jump in?
Please.
So I would say, from my perspective, when you're talking about primary care practice improvement, the lead role there is really the Blueprint for Health, which is part of the Agency of Human Services. They, and I don't want to speak for them obviously, but their role by statute is to work with primary care, help primary care practices create medical homes. Part of their program is funding community health teams, and they also have a practice transformation component. So in the primary care space, they are really in the driver's seat, and that's been in existence since 2005, so it predates the regulatory role. I think where we start to come into that space is around the hospital sustainability work, in terms of ensuring that as we move forward with that work, understanding what sort of transformation resources might be needed by hospitals to be able to think about how to improve quality, or whatever the issue is for them. How do we ensure that they have those resources that are needed? So I would say that's still nascent right now. We're still trying to figure that out with AHS, quite frankly, because they have, from the Blueprint, the real expertise from a primary care perspective, at least, on how to move forward with that. But it's a really important piece of the puzzle. I think what the Blueprint really did super well is they didn't just go for, we're going to change payment, but they did, we're going to change payment, we're going to think about care models, and we're going to think about that transformation resource.
And as a follow-up, do they do, or are you working to look at any sort of operational improvements, back office? I mean, those are definitely related to being a good workplace, right? As well as making things fiscally
responsible, right? Absolutely. I think, for the Blueprint, I'm a little out of date at this point. And so I would
in on next week.
Yeah. So I would encourage you to talk with them about that. When I was more closely working with them in my prior role, which is now 7 years old, so take it with a grain of salt. They had practice facilitators that would work directly with the primary care practice to do exactly what you're talking about, change the back office and the workflow in the office. And I don't think we're quite there yet on the hospital sustainability work, in part because when we the transformation work was actually not funded last year. And so we need to, if we can do it with the money that we have, absolutely, it's a priority, but we need to kind of figure out how that would work, where it should live, and whether the money we have is sufficient to do that or not. Yeah.
Any other questions for Ellen and Robin? No? Great, thank you both so much. Thank you.
Before we go, I just want to say one thing, which is thank Julia and Susan Barrett.
Thank you.
They put all this together and did a lot of work with me to make sure I could share this information. They spent hours and hours and hours, and so I just wanted to thank them.
Yes, no, thank them for us as well. Susan has always been very responsive to this committee, as has all of your staff, so we appreciate it.
Great.
Great.
Thank you.
Thank you, Susan.
Yeah.
Excuse me, can we just wait until, so if you want to meet with them outside the hall, but we're going to continue with our meeting. If we are done, actually, we're done unless there's anything from me. We will be back here, you're on the floor at 10, today's Friday, right?
Yeah.
Floor at 10 on Tuesday, and then we'll be here at 1, and I will get the BAA information over to everyone, just in case. We have our folks who are going to be experts on it, but in case you want to look at it before next week. And